Good morning, and thanks for joining us for Ohio Medicaid Basics 2019. Before we get going, I'd like to let you know that the slides for today's session, as well as a recording of the webinar, will be available on our website shortly after the webinar concludes today. So feel free to visit hpio.net for those resources. We'd like to have a real dialogue with you today during the webinar. So we're going to do a couple of things to facilitate that. We're going to have some poll questions for you to answer and engage with throughout the webinar. We'll also have time for Q&A at the end with all of our speakers. And we invite you to tweet during and after the webinar, so feel free to use the handles and the hashtag that you see on your screen here. As I mentioned, we'll have some Q&A at the end of our webinar this morning. So please, as you think of questions while the speakers are presenting, go ahead and type those into the question box that you see on your screen on the right-hand side, and we'll get to all of those at the end of the webinar. So here's a look at how we'll be spending our time together today. First, Zach Reet from the HPIO team will present a summary of our Ohio Medicaid Basics 2019 publication. Then you'll hear from two guest speakers from the Ohio Department of Medicaid, Deputy Directors Patrick Beatty and Jim Tassi. They'll address how the recently enacted budget impacts the Medicaid program and what to expect as Ohio goes through the procurement process for managed care contracts. We're grateful to have both Patrick and Jim on the call with us today. So we're going to start today off with a poll question, just to see how familiar with the Medicaid program you are at the beginning of today's call. So go ahead and pick which answer best fits you. Are you very familiar with the Medicaid program? Do you know just a little but not a lot? Or are you here because you're here for a basics webinar and you really want us to start from the beginning? So go ahead and let us know which of these best fits you. No matter where you are at the webinar today, we're going to hit something for everybody. So go ahead and let us know, and we're going to throw the results. Okay, we've got a lot of folks at that midpoint. That's perfect. So we're going to touch a little bit on some basics here at the beginning to get everyone caught up, and then we're going to do a little bit of a deeper dive with our guest speakers. So that's excellent. All right. So now I'm going to pass it over to Zach Reet here at the HPIO team, who co-authored the Ohio Medicaid Basics publication, and he's going to provide an overview of that work. So take it away, Zach.
Thanks, Haley. So Ohio Medicaid Basics is published every 2 years by the Health Policy Institute of Ohio to coincide with Ohio's biennial state budget. It's a foundational summary of Ohio's Medicaid program, and the 2019 edition provides an overview of Medicaid eligibility, updates on enrollment, information about financing and spending for the program, and provides a specific update about enrollment in Medicaid expansion. These are the three key findings for policymakers from the publication. First, Ohio Medicaid provides access to healthcare services for about 3 million low-income Ohioans. While we know that access to quality healthcare is not the only thing that impacts our health, access to healthcare services is critical for people who are sick, injured, or living with chronic conditions. Many Ohioans that rely on Medicaid have trouble accessing or affording other types of health insurance coverage, like that provided through an employer. The second key finding is that Ohio's Medicaid program is costly and that federal reimbursements cover most of the costs associated with the program. In 2018, about 68% of total spending on Ohio's Medicaid program came from federal sources. The final key takeaway is related to recent legislative efforts to restrict Medicaid spending, reduce enrollment, and modify beneficiary behavior and utilization patterns. As Ohio policymakers consider these efforts and the Ohio Department of Medicaid works to implement them, they need to balance Medicaid's critical role in providing access to healthcare with the very real budgetary and administrative challenges that the program presents. Ohio Medicaid Basics was released in April 2019, 2 months before Ohio's 2020 to 2021 budget was passed and signed by the governor. Ohio Medicaid pays for healthcare services for children, older adults, women who are pregnant, parents, adults without dependents, and individuals with disabilities. All Medicaid beneficiaries also have low incomes. Medicaid provides health insurance coverage to about 3 million Ohioans, or nearly 1 in 4 Ohioans. The most recent numbers put enrollment at about 2.8 million, so it has come down recently. As such, this program is a critical piece of the health insurance coverage landscape in Ohio. So now we'll talk about eligibility for Ohio's Medicaid program. As I mentioned, to be eligible for Medicaid, people have to reside in a household that has income below a specific amount. For most enrollees, the income limit is set as a percentage of the federal poverty level, and eligibility is based on a household's modified adjusted gross income. This graphic summarizes income eligibility limits for the majority of Ohioans that apply for Medicaid. Children under age 18 in households with incomes up to 211% of the federal poverty level are eligible for Medicaid if they are uninsured. Children with other sources of insurance coverage, for example, employer-sponsored insurance coverage, might be eligible for Medicaid with incomes up to 161% of the federal poverty level. Adults with incomes up to 138% of the poverty level are eligible for Medicaid, and this includes single adults without dependents after expansion in 2014. Finally, women who are pregnant are eligible for Medicaid with incomes up to 205% of the federal poverty level. Once a woman is determined eligible during a pregnancy, that woman will remain eligible for Medicaid throughout the entire pregnancy and for 60 days after the baby is born, regardless of other changes that might impact eligibility. Similarly, a newborn is eligible for Medicaid for a full year after the date of birth. These next graphics provide some context for Medicaid income eligibility. Here's an example. If a child lives in a household with 4 people and has no other insurance coverage, the household's modified adjusted gross income must be $54,333 or less to be eligible for Medicaid. Here's another scenario for a single adult without dependents. The income limit is $17,236 per year. In addition to meeting income eligibility requirements, a person must, at a minimum, have or apply for a Social Security number, be a U.S. citizen or meet Medicaid requirements for people who are not U.S. citizens, and be an Ohio resident. In some cases, disability status and medical conditions are also considered during the eligibility process, and we'll talk more about that in just a minute. Some Medicaid programs also look at assets such as stocks or bonds and real estate, and then there are some exemptions for certain assets, like a person's primary residence. For the purposes of reporting, federal reimbursement, and administration of the program, Medicaid beneficiaries are enrolled into different categories based on specific characteristics. The 4 broad categories that the Department of Medicaid reports on are covered families and children, age blind and disabled, Medicaid expansion, and other. And these are the groups on the slide that are included in the covered families and children group. In state fiscal year 2018, enrollment in the covered families and children category included nearly 1.2 million children and almost 500,000 adults. These are the groups that are included in the aged, blind, and disabled category. To be enrolled in the aged, blind, and disabled category, an individual must be over the age of 65 or determined disabled by the Social Security Administration. Medicaid spending varies by eligibility category, and many individuals that are enrolled in the age, blind, and disabled category have health challenges that are expensive to treat, and therefore spending that's associated with this population is proportionally higher than it is for other groups. Some, though not all people that are enrolled in the ABD category are eligible for both Medicare and Medicaid. And this slide highlights some of the differences between the programs. Unlike Medicaid, which is funded and administered through a partnership between the federal government and states, Medicare is a fully federal program. Eligibility for Medicare is based on work history and age or disability status, and there is not an income limit for Medicare coverage. Finally, Medicaid is funded through income taxes and other fees, whereas Medicare is paid through payroll deductions like premium contributions. In January of 2014, Medicaid coverage was expanded to adults ages 19 to 64 that aren't eligible for other categories of Medicaid and have incomes below 138% of the poverty level. This population or category is sometimes referred to as Group 8. Enrollment in Group 8 peaked at over 725,000 in early 2017, and as of August 2019, just about 606,000 people were enrolled in this category. The final eligibility category that the Ohio Department of Medicaid reports on is Other. And in state fiscal year 2018, about 5% of Medicaid enrollees were enrolled in categories other than CFC, ABD, or Group 8. People enrolled in other categories of Medicaid have access to just a limited set of services, or they are enrolled for only a limited time. For example, the Medicare Premium Assistance Program provides a limited Medicaid benefit that helps cover costs associated with Medicare, and those include premiums and cost sharing like copayments. States are required to provide federally mandated benefits through their Medicaid programs. These include the essential health benefits defined by the Affordable Care Act and early and periodic screening, diagnosis, and treatment, sometimes referred to as EPSDT services for children. Ohio provides some additional services that are not federally mandated. Examples of these include vision, dental care, and also prescription drug coverage. Some services provided through Medicaid require a determination of medical necessity, a prior authorization, or a copayment. Medicaid coverage is delivered through managed care plans or through a fee-for-service arrangement. Managed care plans are privately operated health insurance companies that contract with providers, such as physicians and hospitals, to deliver the Medicaid-covered set of services to enrollees. As of July 2019, over 90% of people receiving full Medicaid benefits in Ohio were enrolled in a managed care plan. In state fiscal year 2018, Ohio Medicaid's average monthly enrollment was about 3 million Ohioans, and that represented a decrease in average enrollment of more than 80,000 from state fiscal year 2017. As I mentioned earlier, enrollment has continued on a downward trend in 2019. Medicaid enrollment in Ohio is impacted by a number of factors. During periods of economic downturn, unemployment and underemployment rises, incomes stagnate, and people tend to turn to safety net programs like Medicaid, which leads to increased enrollment. The opposite can also be true. A strong economy can lead to reductions in enrollment as people return to work more hours, or earn more. Policy changes, like the expansion of eligibility to adults without dependents that's seen in this slide in 2014, can also have a major impact on enrollment. Medicaid Basics outlines 4 reasons that people enroll in Medicaid as opposed to other types of health insurance. These include unemployment, divorce, or other changes that could impact access to other types of coverage, such as leaving work to take care of a child or a relative. Another reason is that private individual health insurance is very expensive and difficult for many families to access. And finally, some people are in need of long-term services and supports, like the services provided through a nursing home, and those are not covered by Medicare and other types of private health insurance coverage. This graphic illustrates the fourth reason that was discussed in Medicaid Basics. The likelihood that an individual with low income has employer-sponsored insurance coverage increases with household income. Nationwide in 2017, just 33% of workers in households with income below the poverty level were offered employer-sponsored insurance, and just 19% of part-time workers had that same offer. Ohio Medicaid is financed jointly by the federal government and states through a reimbursement arrangement called FMAP, or Federal Medical Assistance Percentage. States are reimbursed by the federal government for healthcare services provided. States are eligible for increased reimbursements or enhanced FMAPs for some children and for people that are enrolled in the Group 8 category of Medicaid. Ohio's regular FMAP for federal fiscal year 2020 was 63%. Total spending on Ohio's Medicaid program in state fiscal year 2019 was nearly $26.8 billion, and the federal share of the program was $18.3 billion. Ohio's General Revenue Fund, so in other words, Ohio's income tax revenues, contributed $5.2 billion, or 19.5%. The remainder came from other state sources, including fees paid by hospitals, health insurance companies, and nursing facilities. Total spending on Ohio's Medicaid program has grown 95% between 2008 and 2019. The federal share of the program has grown 125% compared to 52% growth in Ohio's share. As a reminder, here are the three key takeaways for policymakers from the brief. If you have any questions about my segment of the presentation, please go ahead and type them into the question box now while they are fresh. After we hear from our guest speakers, we'll answer some of your questions. And now I'm going to turn it over to Patrick Beatty, Deputy Director from the Ohio Department of Medicaid, who is going to talk about provisions in the budget that will impact the Medicaid program.
Thank you very much. So my name is Patrick Beatty. As Zach indicated, I'm the Deputy Director and Chief Policy Officer for the Ohio Department of Medicaid. And we've got a brief slide presentation for you. I'll be covering some highlights of the budget. So we provide healthcare coverage for nearly 3 million Ohioans who've served by a network of over 135,000 providers. Ohio Medicaid ensures that healthcare access to low-income adults, children, pregnant women, seniors, and individuals with disabilities. Over half of Ohio's births are covered by Medicaid. More than 1.2 million children are served by the Medicaid program, and approximately 36,000 children in foster care are served by Medicaid. As part of our initiatives this biennium, we are investing in recovery. We are collaborating along with a host of other state agencies and private industry representatives with the Recovery Ohio Initiative and the Department of Mental Health and Addiction Services, the Department of Health as well. And we are seeking to strengthen access to care and improve outcomes for Ohio's opioid epidemic. We also are moving forward with implementation of an 1115 substance use disorder services waiver, where we'll have expanded options and flexibility and tools to address SUD issues in the state of Ohio. We are pursuing sustainability, quality, and access. We're going to be and Jim will be talking about this in more detail, but we're going to be doing procurement of new managed care contracts. We are going to be working on the Medicaid expansion work and community engagement requirements, where we'll be providing connections and employment support and wrap services through ancillary organizations to help people who are in the Medicaid expansion group to attain and maintain employability. We're going to modernize Medicaid's pharmacy program and implement a unified preferred drug list. This is going to create administrative relief for physicians who will only have to resort to one preferred drug list rather than 6. We're going to be developing a selection process and choose a new single pharmacy benefit manager by July 1 of 2020. This will enable the state to have greater insight into the delivery of pharmacy services, pricing of pharmaceuticals, and will provide for greater efficiency. We're going to be working on program performance, accountability, and sustainability. We're going to be increasing the managed care withhold, and we're going to be updating the member month reconciliation process. We're going to be investing in kids, healthy moms and healthy babies. We're going to be have continued infant mortality grants in 9 counties. We're going to be developing maternal and infant support program, including home visiting. And we're going to be developing and implementing a mom-baby dyad care for moms with SUD and babies with NAS. We're going to be pursuing behavioral health in schools. Hospitals can play a critical role in supporting healthcare, including BH in schools, particularly in underserved communities. We'll be coupling that with utilizing new tools, such as telehealth, to increase access and support. We're going to be providing support for child protection transformation and multi-system youth, which will include examination of things like PRTFs. We're going to be developing wellness for kids through comprehensive primary care, CPC. We presently have CPC, which is primarily focused on the adult population. We're restructuring that program to increase emphasis for primary care services for children. And we are increasing or moving forward on lead testing and hazard control. So there are many pharmacy changes in House Bill 166. We have the authority to pursue a single pharmacy benefit manager. We've got an additional $100 million for high Medicaid volume pharmacies through supplemental dispensing fees. We're going to maximize drug rebates through direct negotiations and increased transparency. Legislation prohibits specialty pharmacy steering by a PBM, and we'll be implementing a pilot program for pre-audit processing of pharmacy claims. We're going to have increased pharmacy transparency, which has been discussed much in the past few years. And these tools will include a unified preferred drug list. We have implemented the pass-through model, and we will continue to monitor how that affects delivery of services and pricing of services. We are eliminating conflicts of interest where PBMs will steer patients to their own pharmacies rather than competing pharmacies. We're going to have compliance auditing of PBMs. We're going to have increased transparency into PBM contracts in partnership with our managed care partners. We're increasing and enhancing our data analytics in the space of pharmacy delivery. And we're promoting safe and effective use of medications. We have made significant changes to behavioral health payment rates. Services with adjusted Medicaid payment rates were effective August of 2019. Those included crisis services for mental health and substance use disorders. It includes group psychotherapy and group therapeutic behavioral services, TBS, for MH, and group counseling for SUD. The evaluation and management services and psychiatric diagnostic evaluations rendered by clinical nurse specialists, certified nurse practitioners, and physician assistants are increased from 85% to 100% of the Medicaid maximum rate. Payment rate updates apply to community behavioral health providers, as well as the outpatient hospital behavioral benefit. Services added to the behavioral health package were effective August 2019, and they included smoking cessation counseling and pregnancy testing. And now I'm going to hand it off to Jim Tassi, Deputy Director for Managed Care Procurement in the Ohio Department of Medicaid. Thank you.
Thank you, Patrick. All right, thank you, Patrick. As Patrick mentioned, I'm Jim Tassi. I'm the Deputy Director leading the Medicaid Managed Care Procurement. Went too far, got over anxious. There we go. So before you, this is our mission statement as we are thinking about not only the managed care procurement, but also really kind of the Medicaid program as a whole as we move through the procurement process and beyond. There's a lot that I could say about this particular mission statement. There's both a kind of a practical component to it as well as a philosophical one. The practical component to it is that for those of you who are familiar with our program, and even for those of you who are maybe among those like 15% who are newer to the audience, it's been about 7 years since the last time we did a managed care procurement. We have had the same 5 health insurance corporations as our managed care plans since about 2013. And so a lot of the changes, a lot of the programs that we've talked about, even some of the things that Patrick has talked about this morning, have all been kind of developed and designed with that foundation, with that kind of structure in mind. And you know, as we are looking to redevelop those managed care contracts and to think about what the Medicaid program will look like for the next several years into the future, it gives us the opportunity to take a step back and focus instead, not so much on the, you know, how many plans we have or what the business structure is of a managed care model, but to look at what the individuals whom we serve and what they need first, and then develop and design our program around that. So that is kind of the basis for the statement from a practical perspective. From a philosophical perspective, I mean, it's very much the same thing. I mean, we want to turn our focus even more so than we have historically to the individuals whom we serve, also looking to our providers and other partners for their support, and also, you know, to learn more about their experience. I'll say more about that here in a moment. Generally speaking, our managed care procurement project plan goes across 4 phases. We are currently in just phase 1, which began with a request for information that we issued on June 13th of this summer, where we are looking to get feedback from individuals and providers regarding their experiences with our program. As I mentioned, we released a request for information on June 13th. That is still open. Originally, we had announced that we were going to close that on about July 31st, but we have left that open, and I'll talk a little bit more about various ways people can get a hold of us. But this has been a very useful tool so far, as we have been working through the process. We've received about 480 individual comments from various both members in our program, providers, provider associations, advocacy groups. About 151 of those have been specifically from individuals served by our program. The thing I will say about the request for information is it was intended to really kind of facilitate the dialogue and kind of the spawn thought, but we are not expecting and you know, nor do we believe that folks should feel constrained by, you know, the questions that are on that request for information document. And so in fact, a lot of the 151 or so comments that we've received from individuals so far have been kind of more of a narrative. They've been a story about an experience that an individual has received or has experienced going through our program, or something that they've heard about that maybe their neighbor has experienced, or maybe from a provider's perspective, some of the either challenges or successes that they have seen in working with our program. And we are welcoming that sort of feedback even today, even into the future, because we look at that, and we then kind of realize that there is something important there that someone is trying to say to us. And so something has caused someone to take the time to reach out and provide a response. And so we want to take the time to think through that, occasionally following up with questions if it's not quite clear to us, what the circumstances were. But then really using that as we are thinking through the development of our new system, how can we, for one, potentially address that challenge, or if it's something out there that is working well that folks really want to see continue or maybe expand, we want to hear about that too. We are going to keep that phase, our first phase, open for the next few weeks. I'll talk a little bit more about some of our future activity in a moment. But once the first phase closes, we will then move to the second phase of our procurement, which will be a second request for information. And that one will be much more vendor focused. It will be more structured. There will be a specific time frame within which potential vendors will have to have in order to respond to us. And it's going to be fed or designed around some of the feedback that we've received in response to the first request for information, some of the research and development that we are also doing on our own across about 100 or so people within the Department of Medicaid who are working on the procurement. And it will basically pose questions that will be a combination of, here's a design hypothesis we're considering, tell us about your experience in your work either with Ohio or with another state. But it also may raise some challenges that just candidly we have not thought through the answer to. And so getting more feedback from potential vendors about, well, if we recognize that this is a concern that we want to address, or this is an initiative that we would like to move forward with, tell us how you would go about helping us with that. And so as I mentioned, that will probably come out later this fall, very early this winter. After we've taken all of that feedback into consideration, spend some more time kind of digesting it and designing things, we intend to release our requests for applications, which will actually be that competitive document into the year 2020, early 2020. It will be by its very nature, a competitive and quiet process as we go through the scoring. We will then, after we have scored the various applications, issue our notice of intent to award to our selected vendors. At that moment, literally on probably the day or the next day after we announce who those intended vendors will be, we will actually begin our implementation and readiness review process. We anticipate that there may be some protests to the selections we make, and while we hope that there's not litigation, we recognize litigation as a possibility. But we still intend to move forward with our readiness review process with our intended vendors, barring anything that tells us we need to stop, so that we can continue that, so that we can begin that process as early as possible to get our new vendors acclimated to the expectations that will come to them by virtue of being part of our Medicaid program. That providers will be given the information they need to think about, any kind of transitional issues that they might be faced with if a new vendor is brought into the program, or if people within their client base has to move from one particular vendor to another, things along those lines. Similarly, we are going to be working to ensure that individuals are prepared for any transitions that may come to them. Making sure they have the support, making sure they have the information, thinking about how, the different services that an individual might be receiving will interact within the new program. And so, really kind of making sure that everybody external to the Department of Medicaid is prepared and ready for the transition, but also looking at ourselves internally at the Ohio Department of Medicaid and thinking about what this new opportunity with these new contracts does for us in terms of a program, and how we can better manage the Medicaid program as a singular program that we have the discipline to have ownership over, but also working with our managed care vendors to ensure that the program is working well for the individuals whom we are collectively serving, as well as the providers who are our partners in moving through the process. Again, we cannot overemphasize this enough. We really do want to continue hearing from individuals and providers in particular. As I've mentioned, we've been engaging stakeholders early since June. Our email address is always open, even after we, officially or unofficially, I don't even know if it's official or unofficial, but when we turn off, for example, phase 1 and move to phase 2, that email address will still be available for folks. It's really important to us that we get not only ideas, but perspective and feedback in terms of our program. And so, again, just to say it out loud, anything that anyone wants to share with us with regard to their experiences with our program, or even experiences that they wish they were having with our program that maybe they aren't. Those are the sorts of things that we're looking for in the types of feedback that we hope to attain. There are many ways that we can get input. I know a lot of you in the audience today may have, either folks whom you work with or peers or things. And so, I'm going to entreat upon you to help us as well as I'm talking to you today. But there are many ways to interact with us as we go through this procurement process. As I've mentioned a couple of times, our email address, mcprocurement@medicaid.ohio.gov, is always open. Folks are welcome to email us there. They can send us attachments. Attachments generally work. Sometimes we have a day or two delay with our spam filters, but assuming that they are good, we can get those. We have received a few pieces, I would say not as much as I would have expected, of actual hard copy mail. As long as they are addressed to the Department of Medicaid and they mention managed care procurement on them, they will eventually get to us. We do have a more specific address on the request for information, so you can always look at that too. With regard to the request for information, it is still available online. We have modified it to make it a fillable PDF form. So if there are folks out there who are interested in specifically answering the questions, but don't want to go into the difficulty of either having to restate the questions, either in an email or through a Word document, that fillable PDF is available for folks. We have been meeting with various groups, including HPIO, for example, different advocacy organizations, provider associations over the last couple of months to kind of get their views of our program and their experiences with managed care and some of the successes and challenges that they've seen over the last few years. We are about to transition into having some small group meetings around the state. We don't have all of the details fully locked down yet, but approximately 20 small groups that we are going to be having, as I mentioned, kind of all over the state, Southern Ohio, Northeast Ohio, Northwest Ohio, and on, where we actually want to meet with individuals who are served by our program. And that conversation by necessity is really going to be more about like just learning about the individual's experience with our program. I mean, we're not going to ask questions like, well, what do you think about managed care procurement? Because we recognize that, there's probably about a handful of us who really think about it in those terms. And so again, it's really going to be a way to allow us to get some more feedback and some more information throughout this entire process. I will say, even as somebody who's been with the Medicaid program for about 11 years now, I have learned a lot already in just meeting with the various groups across the state. And I'm looking forward to having some more direct interaction with individuals whom we serve as we move forward. And so I believe that is my last slide.
Thank you so much, Jim, for that overview. We're going to be heading into Q&A here in just a minute, so this is a great opportunity for you to throw your questions into the question box. I've seen a couple come through. We'd love to have some more. And as you're thinking about that, I want to let you know about an in-person event that we have coming up here soon. So on October 2nd, HPIO is hosting a forum focused on healthy behaviors and personal responsibility. And this forum will explore the role of both policymakers and other stakeholders and how the role that they play in engaging people in their own health. We're going to have Joan Alker, who's the nationally renowned speaker, joining us, as well as Representative Jim Butler from the Ohio House, and a slate of other excellent speakers. So if you would like to be here for this event, you can join us at hpio.net/events to register for that. And in that vein, I'm going to ask our guest speakers our first question, and that is, so in the request for information, the RFI process regarding the managed care agreements, there's a question about how Medicaid and managed care can address health behaviors for members, including tobacco use, nutrition, and physical activity. So can you tell us, either Jim or Patrick, about how Ohio Medicaid is currently approaching addressing healthy behaviors and how that approach will change through procurement and other Medicaid initiatives?
Sure. So I'll try and talk about the present state of affairs and then hand it over to Jim to talk about what we're thinking in terms of procurement opportunities. So presently, one example of how we are addressing healthy behaviors, I had already mentioned that we had taken steps in the biennial budget to increase access to smoking cessation. We coordinate presently with the Department of Health on issues like that, and they have the Tobacco Quit Line and programs like that. With each of the managed care plans, they presently have some of their own initiatives in the space of healthy living and that kind of stuff. But they're encouraged to do that, but we don't have a full-on comprehensive strategy around that. Out of the biennial budget was terminology calling for a pilot around social determinants of health, which really focuses on the whole of the individual and their living situation. Some of that may address in the context of healthy living behaviors, and others are matters that really are attempts to address ancillary struggles or challenges that individuals may have, whether it be food insecurity, housing insecurity, and the like. But in terms of our plans moving forward, I'll let Jim delve into that.
Thanks, Patrick. Yes, so it is, without getting into a lot of detail, because we're not allowed to kind of let the cat out of the bag too early on some of the things that our potential vendors will be bidding on. But obviously, we want to continue to build on some of the items that Patrick just mentioned to the extent that we are seeing success with them. I would say one of the things that we have learned through meeting with various groups and individuals from around the state already is that we need to do a better job as a state in coordinating some of those services, not only across the different state agencies, but also with our local partners. And so, that's one of the things that even kind of outside of the actual procurement vehicle that we need to think about and that we will be spending some time with. From a design perspective, from a managed care procurement perspective, we will be looking to potential vendors to tell us how they will help us in that regard, but also other new or innovative ideas that they may have of their own making or based on things that they have seen in other states. And so a really big part of our plan going forward is to obviously build on the successes that we have. We don't want, for example, the Department of Medicaid's progress on things to stop waiting for these new contracts. So we are going to continue to work on these issues as they develop and then kind of weave those into what the procurement actually looks like.
Thank you both. So we're having a slew of questions coming in, and so I'm going to try to bundle them together a little bit so that we can get some sort of group answers going. So first, sort of some nuts and bolts questions. How long will the implementation phase of the RFI sort of procurement process last, and what is the anticipated effective date for new vendors?
Sorry, I got to click happy on my button. So I will say that we don't have a definitive either timeline or date for those that that we are prepared to share yet. We have looked at what some other states are doing, and typically that implementation readiness phase is generally at least 6 months. We know that some states have taken significantly longer than that. I think the important thing to say about this particular question is, while implementing this new system is something that's important to us and important to the governor and the administration, we also want to make sure we're doing it correctly. And so what I don't want to do is throw out a date or say we're going to do it by a specific date and then feel like we're constrained to hit that particular date if we're not ready to actually do the implementation or do the transition. Part of it is also just by the nature of how these things work, going to be dependent upon what our vendor mix looks like after the procurement. If we do have carryover plans, we anticipate that we might have some more of a kind of like phase transition to the new system. So those are all still things that we're kind of thinking about and planning for, but we don't have like a definitive kind of schedule for at this point.
Great, thank you. Another question sort of pertaining to the RFI process. Has any information come out of that illuminates the reasons for the drop in Medicaid enrollment that we're seeing? A couple people asked about that Medicaid enrollment drop, and one of those folks is in a hospital setting. And that person noted that hospital self-pay, they're noticing, is increasing and Medicaid is decreasing, which indicates to them that those folks are not on employer-sponsored insurance. So either of you, any thoughts related to that?
Sure. So we've been looking at this, and the trends are consistent with the other public service benefit programs, SNAP and TANF, which are also experiencing a decline. And the most significant factor is the decrease in the unemployment rate overall. We're finding that individuals just are no longer qualifying for Medicaid. They may not be accessing insurance through the marketplace or through employer-sponsored insurance, but they may be finding themselves no longer financially eligible for Medicaid. There is some view that the elimination of the marketplace assisters may have an impact on that, but I don't know that we've definitively identified that.
Great, thank you. We had another question about centralized credentialing, if that is being thought about and what the timeline might look like.
Yes, we are actually moving forward with centralized credentialing of providers. I do apologize, I don't know the timeframes that we anticipate on that, but essentially it would provide for one portal and process for credentialing rather than having to credential separately with each managed care plan.
Thanks, Patrick. And this is a webinar about basics, so would you mind just giving us a little bit of the background around what centralized credentialing is about?
Sure. So in order to participate as a Medicaid provider in the Medicaid program, each provider has to apply for and get a Medicaid provider ID. And part of that process includes being what we call credentialed, which is verification of qualifications, licensure status, and any other criteria needed to verify that you aren't excluded from the Medicaid program. Presently, each Medicaid managed care plan manages its own credentialing process. So if a provider wants to become a Medicaid provider, they have to get both a Medicaid ID and get authenticated by the Medicaid managed care plan in order to participate.
Thank you very much. Thank you. So this question takes it back to Jim. So how is the Department of Medicaid getting the message out about the RFI process and receiving that feedback? And is there any role that Job and Family Services is playing in that?
Yes, thank you. So we've kind of had a couple of different approaches to it. We very early on basically updated our Ohio Department of Medicaid website to, on its front page, be very much about the procurement and about the RFI. We have since been developing a new Medicaid managed care procurement website that is in the design phase right now. We're hoping to bring it live in November. And so that will be both a way to share information about not only this first RFI, but really where we are with the project going forward, as well as continuing to receive feedback. Just this past Thursday and Friday, we met with the county JFS directors and met with their exec board on Thursday and had very good dialogue with them with regard to some of the concerns and some of the things that they are seeing on behalf of the people whom they serve, and also kind of talk to them about meeting with them and talking with some of their frontline staff to get a better feel for what our program, how it relates to them and how their interaction with the managed care plans work. We have developed a kind of postcard, if you will, that has feedback information on it in terms of how people can get a hold of us. We distributed those to the county JFS directors to take back to their county offices so that they would be available for folks to see. We, as I mentioned, are going to be doing these 20 outreach meetings throughout the state. And so the organizations that we are partnering with to host those will be provided with like flyers and other communications to get the word out. So, and then finally through our Department of Medicaid social media, like our Twitter account and things like that, we've been sending some stuff out.
Thanks, Jim. So this is a question about that Group 8 group that's eligible for Medicaid and what happens when those folks, their incomes increase and they're no longer eligible for Medicaid in that group. Is there a strategy that the department is working on to assist current Medicaid clients in transitioning to marketplace plans once their incomes exceed that 338% FPL?
That's a really good question. As we sort of move forward on developing the operational components of the work requirements waiver, one of the things that we're looking at is what tools do we have available for helping individuals get access to employment and maintain employment. But part of that equation also includes working with the Medicaid managed care plans to evaluate whether or not they can facilitate individuals transitioning from one form of health insurance coverage to another. Each of the Medicaid plans also participates in the marketplace. So there are opportunities there for that. That said, there is a really big challenge in accessing or affording services, healthcare coverage in the marketplace. And depending on what kind of income level an individual has, the higher their income level goes, the lower their sort of federal subsidies becomes. So it really will depend on the individual and their situation to figure out how best to help them transition to private coverage. In an ideal world, you would have employer-sponsored coverage, but that is oftentimes not an option. And so we'll be looking at ways to help support that.
Thank you very much, Patrick. Sort of in that same vein, we have a couple of folks asking if there is any concern that Medicaid expansion, that Group 8 group, would no longer be included in the Medicaid program. Is there a concern about Medicaid expansion going away?
Our focus isn't on the Medicaid expansion group going away. Our focus is on helping that group succeed to the best of their ability.
Great, thank you. We also have a question about housing. So is there any collaboration between the Department of Medicaid and healthy and safe housing initiatives at the local level?
I will have to confess that I am not an expert on this. I know through some of our relationships with like the Ohio Housing Finance Agency and a couple of our waiver programs that those are things that we've been talking with folks. Candidly, it's one of the things that we also want to hear more about as we're going through the procurement process, and how we might be able to either incentivize managed care vendors to work with local housing agencies, for example, to help develop things. Or, conversely, are there things that we as a program should be doing or could be doing, recognizing that the Medicaid program itself can't directly pay for housing?
Okay, well, that looks like the end of the questions that came in during that time. We're so thankful for everyone being on the webinar today. Thank you again to Zach and Patrick and Jim for their work on the presentation and all the information they shared with us. We are going to throw one last poll question just to assess kind of how you think we did on the webinar today. We want to make sure that we're bringing you quality information and that this space is serving you well. So let us know how you think today went. We really do value this feedback, and we work to make sure that this space is a good place for all of you. So, all right, we appreciate you giving us that feedback. We'll leave it up for a few more minutes to make sure that folks have a chance to vote. And if there are any additional lingering questions that you all have, please feel free to throw those in that question box for the next minute or so, or you can send us an email, either Zach or Alana or whoever's email you have on our team, and we'll make sure those get to the right people and that you get your questions answered. Okay, thank you very much. And with that, we'll leave this up. This is a place where you can see the brief that Zach presented on the webinar today. This is where you can find that on our website. And again, if you have any additional info or questions, please feel free to reach out to us with those. And with that, we'll say thank you again for attending, and everyone have a great day.